It's my pleasure to introduce Marie-Claude Rousseau, who's really done the tour of the Montreal universities as part of her training, but highlights were master's and then a PhD at McGill in epidemiology and then a postdoc at the University of Montreal. And now, as you see, and as we've been discussing, she's at the Institut Armand-Frappier, where I had some dealings long ago when I did my master's with the same BCG registry, and was very delighted when some years ago Marie-Claude contacted me. She was planning to put the whole thing digital and use it as a great resource. I actually got a CHR CFI for that. So Marie-Claude, also collaborated a little bit with her. She's absolutely my favorite collaborator. She sends me papers that are totally polished. All I have to do is correct my name occasionally. That's what it. Very high quality research that I'm sure you're going to see another example of now.
All right. Is it on? So thank you for having me today. I'm delighted to be speaking to this group. I'll be sharing with you some of my research on a cohort study that we conducted in the Quebec population on BCG vaccination and childhood asthma, and for which we used administrative data and a two-stage sampling approach. So I thought that substantively and also methodologically it could be interesting. The outline of my talk, I'll start with a brief background on why are we interested in studying BCG vaccination in relation to childhood asthma, and what are the advantages of studying this research question in the Quebec population. I'll talk about the methodology both of the birth cohort per se and of the two-stage sampling approach. I'll share with you some of the results, and I'll introduce some of the recent developments that we've done with this research infrastructure. So, asthma in Canada, the age standardized incidence is at about 500 per 100,000 persons. That's according to the latest report from the Canadian Chronic Disease Surveillance System, and that's based on data from 2011 and 2012. And in these years, there were 3.8 million, almost 4 million Canadians living with asthma, representing about 11% of the population. In terms of prevalence, this is an increase of about 67% from 2000 to 2001, and the steepest increase was seen in the age groups 10-19 and 20-29. If we look at the prevalence, you see this is the prevalence by age group, and the males are depicted in green and the females in blue. And what you can see is that, first of all, the prevalence is higher in childhood and teenage years, and that also one of the notable facts is that the prevalence is higher in these years among males and then becomes higher in females later on. Asthma is characterized by chronic inflammation of the airways, and the risk factors, actually the causes, seem to be quite multifactorial and complex, involving genetics and environmental factors as well. Some factors of the host that have been identified include sex, family history of asthma and allergic diseases in general, allergic rhinitis and atopic dermatitis, low birth weight, and obesity. Some environmental factors have been identified, for example, tobacco smoke, air pollution, dust mites, exposure to domestic animals for which the associations with the risk of asthma are quite inconsistent and across studies, and also depending on the age at exposure that you consider. Occupational exposures are also associated for adults. Other factors that have been identified include respiratory diseases and antibiotic use in infancy, breastfeeding as a protective factor, and socioeconomic status. Some of these factors are risk factors, and others might be triggers of asthma attacks. It's very difficult to get a clear picture of what are the main etiological factors associated with asthma. Now, given that chronic inflammation of the airways is an important landmark of asthma, and the importance that we've seen among the different risk factors that were identified of early life exposures, I and my research team started thinking about what if the incidence of asthma was related to factors that can modulate the immune response in early life. And this led us to think about immune modulation from BCG vaccination, partly because we had, as you mentioned earlier, we had the BCG registry at Armand-Frappier Institute, but also based on existing experimental evidence. So we know that BCG vaccination stimulates macrophages, that it stimulates the Th1 immune response and regulatory T cells, and decreases the Th2 immune response. And so it does have a strong impact on adaptive immunity and favoring a Th1 type immune response, so a cellular immune response rather than a humoral immune response. But this we know from experimental evidence. It's also been described very recently, actually, that BCG has an effect on innate immunity through epigenetic programming, whereas through a process called trained immunity, it generates trained monocytes and macrophages and creates basically a memory response, but from the side of innate immunity. Around 15 years ago, I would say, the concept of immune homeostasis was put forth and was quite refined over the years. But basically, the idea was that there was an equilibrium between the Th1 response, or the cellular immunity, and the Th2 response, or the humoral immunity, brought about not only by inhibition from Th2 lymphocytes onto Th1 lymphocytes and vice versa, but also regulated by regulatory T cells. Now, Th1 immune response is often characteristic of autoimmune diseases, whereas a Th2 immune response is one of the features of allergic diseases, and asthma. So the hypothesis that we were interested in investigating was whether early life environmental exposures, and basically occurring at a very early period in life when the immune system is getting trained and maturing, and that's mainly within the first few months and first year and couple of years of life, whether such factors could have an impact on the balance of the different processes, Th1 and Th2 processes, and then affect disease risk later on. And basically, the marker of these early life environmental exposures that we chose to look at is BCG for the reasons that I explained earlier. Now, BCG is Bacillus calmette-guérin. I should have explained that a little bit earlier, but it was developed at Institut Pasteur in France. in the 1910s and early 1920s. It's actually a non-pathogenic strain of attenuated live Mycobacterium bovis, and it's been used for decades and decades in tuberculosis prevention. Why is it specifically interesting to look or to study this vaccine in Quebec? Well, first of all, there was a province-wide BCG vaccination campaign in the 50s, 60s, and the early 70s. One of the interesting aspects was that the vaccine was given free of charge, but it wasn't mandatory. So as opposed to other countries in the world where vaccination was mandatory or almost universal, at least here you can have some contrast in the population with a fair proportion of the population that hasn't been vaccinated, which is not necessarily the case everywhere in the world. And the people who were targeted by the vaccination program were newborns, firstly, then school-age children, and people who were considered to be at higher risk of TB, either at home or through their professional activities. One of the interesting aspects that is specific to Quebec is that we have a registry from the vaccinations that were conducted in the province. And actually, the registry was started in the 1920s, so long before the vaccination program was put in place, and it was stopped about 20 years after the vaccination program ended. So the immunization records were sent to the central registry that was kept at Armand-Frappier Institute, where I work now. And it's still there. It contains 4.2 million vaccination certificates covering the entire province and from the 1920s to the 1990s. And it's been indexed over the years. It's difficult to describe, but it's been indexed in series of books. It would be like if you wanted to search for your vaccination record, it would be like searching through a series of phone books for your name and its name and birth date, for example. It's all in alphabetical order. That's very nice and, serves a historical purpose to look at this, but it doesn't help us for epidemiological studies to be conducted on a population basis. So what we did in 2010, I was successful in obtaining an infrastructure grant from the Canada Foundation for Innovation, which allowed us to digitize the registry. Now, the first part of the registry up until the mid-1950s was on microfilms, and basically we have the graphical images from these entries, but they're not usable as a database for the time being. However, we were able to digitize all the entries from 1956 and convert them into a searchable database using scanning, optical character recognition. So basically we were able to go from the image on the left, which is all the different little cards, to the phone books that you would look through, to an environment where you can actually do a search for a specific person and birth date, and also on the right to a database that can be extracted for analyses and that can even be linked with administrative databases or databases from other sources. So this was really a turning point in terms of being able to use this data, not just in small studies where we would do a manual search to be able to retrieve the vaccination history of subjects, but actually be able to use it on a larger scale in the population. Yes. There's identifying information. So there's Well, of course, name, family name, given name, the birth date, the name of the father, in some instances, the name of the mother, the year of vaccination, and whether there were some tuberculin skin tests that were done, and if they were done, what was the reaction. So it's not all the information that we have on the vaccination certificate, but it's but the information that we have for everybody. Yeah.
So for every birth year, you would have the proportion of children that were vaccinated. Okay.
Mm-hmm. Yes.
Since 1926. And also at birth and in school.
And in school years as well. From 1926, I think that if we think about completeness of the registry, I'm not sure about before the start of the official vaccination program. But when the program was put in place in 1949, there was the guidelines were that, well, you vaccinate, you send the certificate to the registry.
Because there's no unique identifier.
No.
So,
no.
I mean, we have this in global health all the time, where if you spell somebody's name wrong,
Mm-hmm.
it doesn't get linked with the previous or
yes.
or
yeah.
after.
And
so,
we ran into this when we did probabilistic linkage with the databases. But I'll be able to show you some of the. In there, not. But once we link it with other databases, then you can have. I'll get into this a little bit later. Yeah. It's very few, and it's the most recent vaccination years. So in the cohort that we put together, which is the birth cohort from 1974, we did not have that. We just had the father's name. Yes, we would be able to extract it. Yes.
It's unusual, actually.
Mm-hmm.
Because, I mean, you know that the child is the child of the mother, but you don't know that the child is the child of the father, which is interesting.
This reflects the way things were done back in those days. Mm-hmm. Yeah, so we used it for that, but it could have been the full mother's name, but this was not on the certificate. Yeah. Is the father's name still on the rank queue? Yeah. Sorry. Oh, I think it's just the old sexist way that things were compiled. Yes. It was all in listings that had been compiled before, and so we scanned it. So scan and do optical character recognition, and then parse it into variable fields, basically. Yeah. Well, I didn't do it myself. Some professionals did that. Yes. Was offered to infants and to school children. There were actually teams that they call them équipe mobile, mobile teams that would go into different schools and do the skin tests and then come back 24 or 48 hours after, do the reading and the vaccination.
Are you able to tell if this type of vaccination
No, no. To my great disappointment, we don't have the month and the day. We just have the, so we have to roughly say, well, it was in the first year of life. We can't go more specific than that, unfortunately. This information is on the vaccination certificates, but it wasn't entered as part of the registry, unfortunately. So let me just do a brief review of the epidemiological evidence on BCG vaccination and asthma. I got interested into this, but I wasn't the only one. Mariam Elzain, who did a postdoc with my team, did a meta-analysis. At that point in time, in 2008, there had been 23 studies that had been conducted looking at an association between childhood asthma. And I'm not going to show you all of the results and all of the details from the meta-analysis. It's been published. You can go and look at the details. But this is the forest plot from out of the 23 studies. 16 studies had used as an exposure measure BCG vaccination. Others had used BCG scars and tuberculin skin test reaction. We didn't want to use them. So this was basically our best estimate on BCG vaccination and asthma, was suggestive of a slight protective effect in these studies. And this is not the only meta-analysis that was done. There had been an earlier one, and there were two others, one at about the same time as we did, and another one later on. And basically, they oscillate between a slight protective effect and no effect. So they don't give a very good answer to the question so far. Some of the limitations of the individual studies was that you probably saw it from the forest plot. All the individual studies were quite small and very imprecise. There was, in a lot of them, there was a possibility of residual confounding in terms of the factors that had been adjusted for were not necessarily comprehensive. And there's also the issue of possible misclassification of BCG status, because in some of these studies, the information came from self-report, which is not so great for vaccines in general, and is even worse for BCG because some people tend to confuse the tuberculin skin test and the vaccine itself, and so it's been shown that the validity is quite low in terms of self-report, really highlighting the importance of doing these studies in populations where you have registries or good sources of data on exposure. So our study objectives were first to estimate the association between BCG vaccination and asthma in the Quebec population, because we found that it was actually a really good population to ask this question in. Adjusting for potential confounders that were available in the administrative databases, and I'll show you what we had, but we felt that this would likely be insufficient. So the idea was adjusting for other potential confounders that would be gathered directly for a subset of the study population. So it's in this context that I put together the Quebec Birth Cohort on immunity and health, which was used for the BCG and asthma project, but is a wider infrastructure than that, basically allowing us to look at, among other hypotheses, some hypotheses on BCG vaccination and inflammatory and autoimmune diseases. But for today, I'm focusing on asthma specifically. So it's a birth cohort. The eligibility criteria were quite simple: be born in Quebec in 1974 and registered in the birth registry, and born at or after 32 weeks of gestation. And that was to exclude subjects who would have been born premature, who would have had a whole lot of different health complications, that we weren't sure we would be able to adjust for. In retrospect, we could have kept them and just excluded them in the analyses, and that would have allowed us to answer a lot of interesting questions. And so if I could go back in time, I would get them back, but not possible for the time being. In 1974, it's the birth year. Well, we took the birth year because we needed to have an entire birth year to be able to do the contrast between vaccinated and unvaccinated people. As Teresa was saying, that the registry, basically, the BCG registry, tells you these people who have been vaccinated. And we wanted to have the entire birth registry to be able to distinguish between those vaccinated or not. Because among those, it's basically those, yes, because it's among those that didn't link with the birth registry, those are considered the non-vaccinated. And if you don't do it on the entire birth cohort, you can't really. Yeah. Well, there's also, we now have 5. That's the, skipping to the last slide, we now have about 90,000. Yeah. So it was, in terms of feasibility and also the numbers that we had, with this birth year, we estimated for asthma were sufficient, but later on I wanted to start projects on other conditions, and we ended up enhancing to other birth years. And so we had a follow-up through administrative health databases until 1994. Because the focus was childhood asthma, we basically did a follow-up until they were all 20 years of age. If you're interested, all the methodology and some of the results have been published this year in January as a cohort profile. But I'll still go through some of the details of the methodology. So in 1974, there were a little bit over 91,000 births in Quebec. After excluding those who were born before 32 weeks of gestation, that left 90,000 eligible individuals, which we then linked with the RAMQ registration file. For those who have worked with RAMQ data, that's the FIPA, Fichier d'inscription des personnes assurées. And we did this probabilistic linkage using these identifiers, so name, given name, sex, birth date, and father's name. And we excluded about 7,500 persons because linkage was unsuccessful, so they were below the threshold that we were accepting. So in the end, the cohort included 82,600 persons, representing 92% of the eligible subjects. So in terms of linkage between the two databases, we felt it was actually higher than my expectations. Yes. Yeah, exactly. Those would be the difference would be people who were not born in Quebec but covered by the RAMQ. So for data acquisition, now that we had merged the birth registry and the RAMQ files, we had a unique, we had the individual, so we could go and extract the information from the birth registry on top, from the medical services, hospitalization databases, and also from the pharmaceutical databases, which in these years covered very few people, and so far we haven't used it, because before 1997, which is all the case here, the only people who are covered would be those children whose parents were on welfare. That's for this cohort. And we also did an additional probabilistic linkage between the BCG vaccination registry. As was mentioned earlier, there's no unique identifier, so we had to go with the the different identifiers, and there was also a probabilistic linkage that was done with the death registry to identify the subjects who had died. The ISQ did it. Institut Statistique du Québec. Yeah. So they were the ones who did all these linkages. And so in the end, after excluding those that were rejected mainly through unsuccessful linkage here, where we wouldn't be able to decide whether they were BCG vaccinated or not because they had a partial linkage and we didn't want to consider them either vaccinated or not vaccinated, we were left with 81,500 persons, or 90.5% of the eligible subjects. Yes? Sorry? Oh, the telephone survey. I'll get to it very soon. So just before getting to that step, I just want to show you some of the statistics from the full cohort. So 46% were BCG vaccinated, and I'll go into this in more details a little bit later. 51% were males, 49% were females. 30% were living in rural areas, and that's for the year 1991, I think, for which we had the postal code. So using the postal code, we determined rural or urban. We had the quartiles of family income. And some information that was extracted from the birth registry. So about 75% were born from mothers in their 20s or before their 30s, let's say. A little bit less than half had no older siblings. 20% had 2 or more siblings. And birth weight for gestational age was considered to be appropriate for about 67%. No, that was also actually for 1991, for which we had the postal code and we were able to link to that. That's income based on census. I'm sorry, I wasn't specifying the thing. No, this one is not a baseline. Same with the rural urban. These ones, yes, yeah, not the family income and yeah. Yeah, yeah. Yeah. 23% on a reference. Yes. Yeah. We use your reference. Yeah. But it could be. Yeah. Mhm. Yeah. Yeah. Yeah, there. Yes, we used yeah. Yeah. But we could look into this in more details. And actually, we're going through the expanded version of the birth cohort, and so but I don't remember if the distribution is quite similar. But, yes. Yeah. Mhm. Yes. Yeah. No, exactly. There, for sure, this is not one of the top variables in terms of quality, in terms of validity. No, it's true. It's true. Yes. Yes. Mhm. Definitely. Yeah. Yes, absolutely. So I guess this is to be taken with a grain of salt or of criticism. but not in a bad way, but as not necessarily the strongest, the best quality data that there is. Yes.
That's under 1,500 grams, right?
That's no, it's based on gestational age. Yeah. Yeah. Yes. Yeah. And actually, we've done it for a lot of the analysis. So if we go back to the design of the second step, you were asking about the telephone interviews. We're getting there. So we did a two-stage sampling strategy to collect additional potential confounders for the association between BCG vaccination and asthma. And we did this through telephone interviews. And so basically what we ended up having was to be able to measure an adjusted measure of association using exposure, outcome, and some confounders that were available on everybody because they were in the administrative databases, and collecting some additional confounders, potential confounders in a subset. And for this, we used a balanced design. And so I'll get back to that a little bit later. So basically, we interviewed 1,600 people. When I say we, it wasn't me directly, because for confidentiality issues, we didn't have access to the people and the people's coordinates, but all of this was done by interviewers at ISQ, at the Institut de la Statistique du Québec, who had access, but we made the questionnaire, trained the interviewers, and they actually did the telephone interviews. And so through these interviews, we documented a lot of factors, including sociodemographic characteristics, familial and personal history of allergic diseases, including asthma, immunization history. That was quite difficult, but we had a subset who still had their vaccination booklet, and we walked through it with them on the phone. But that's just for a subset. Documented some early life exposures and some environmental factors, and also residential history. So just to give you a little more details about the two-stage sampling, what we did is our stage 2 participants, the 1,600 participants, are actually more or less equally distributed in the 4 cells of the 2x2 table that's created by the main exposure and the main outcome. And basically, to get to that point, what we did is we made the 2x2 table in the stage 1 sample. And basically, if we had subjects for whom asthma status or BCG status could not be established for different reasons, we had to exclude them at that point. We also had to exclude those who were deceased because we wanted to do a telephone interview and we didn't want to use proxies. And we wouldn't have been able to have a phone number at that point in time if they had died 10 years earlier. So from this 2x2 table, you can see, maybe if it's not too small, on the right-hand side, the cells are much larger than the ones on the left-hand side, and that's normal because right-hand side is people without asthma, left-hand side with asthma. And you can see that the distribution by BCG status is more or less, we saw that it was almost half the people who were vaccinated. When we get to the stage 2 sample, it's roughly equally distributed. Now, we lost some people along the way. Among those who were randomly sampled from the stage 1 sample, 87% were found in the RAMQ file from 2010, which is the time at which we did that. So the others, we didn't have their coordinates, so we could not include them. Out of them, we found 70%. There were 70% of the subjects for whom we found a valid phone number, because although RAMQ had the information on phone number, they did not allow us to have it, so we had to do search ourselves. And the response rate from those for whom we had a valid phone number was 56%. So when we look at the first steps that we did was look at the validity of that second stage sample, because it takes, when you're using this to be able to estimate your association fully corrected, fully adjusted for confounders, you're actually taking for granted that in each cell, the subjects are representative of those who were in the cell from the main sample. We often take that for granted, that there's no selection bias, or we try to minimize it, but here we could verify it. So we went and checked it. So comparing the stage 2 sample to the stage 1 sample. And basically what we did is we looked at whether stage 2 participants were representative of the subjects from the stage 1 sample according to different characteristics. We looked at participation rates according to sociodemographic characteristics and also according to healthcare utilization across strata to see if there were differences. And we also estimated the extent of bias when we were looking at the association between sociodemographic characteristics and asthma in the stage 1 sample and in the stage 2 sample, and comparing the two. So what we found for the first point, the representativeness, is that, and this is not surprising, I think lots of people see this in surveys, among participants, there were more women. There were more subjects whose parents were born in Quebec. This we didn't take for granted. It's just something that we observed. And there were more people who were materially and socially privileged. When we looked at income, area of residence, age of parents, at the person's birth, number of older siblings, there were no differences, and there were also no differences according to healthcare utilization within strata. Of course, between the different strata there were differences, but within strata there weren't any. This is the second one, and it actually overlaps quite a bit with the first one. Is we looked at the participation rates according to sociodemographic characteristics across strata, and this is very small, so we probably can't see the numbers, but we see the same factors that I mentioned earlier: sex, maternal birthplace, paternal birthplace, and material and social deprivation. And basically what we see is that the tendencies that we see equally in each of the strata. So there was no interaction across strata in terms of these factors that we saw that affected participation. And finally, what we did is looking at associations between some factors. Here I'm just showing sex and number of older siblings and risk of asthma. We estimated it in the stage 1 sample. We estimated it in the stage 2 sample, and on the right-hand side is the relative odds ratio. So comparing the odds ratio in the stage 2 to the odds ratio in the stage 1 sample. Yes? Yeah. Yeah. Yeah, it's true that there is some difference in there. The other categories are not that different, but this one, yeah. Mm-hmm. But this is, yeah. Yes. Yes, exactly. We're oversampling the asthma, the ones with asthma. Yeah. Well, we said by how much? Well, basically what we said is we went the other way around. We said, okay, to have this precision, assuming this level of confounding, and Andrea, correct me if I'm saying something wrong. So starting with these different assumptions, we said, okay, we need in the end around 400 people in each cell. So we didn't establish exactly, the proportions in the main 2x2 table could change, but in the end, we really wanted, our target was about 400 person per cell according to our sample size calculation. So here, looking at the relative odds ratios for a series of sociodemographic characteristics, we observed, yes?
So you just keep going until you reach 400 more or less?
Well, we randomly selected 1,200 people in each cell to start with. And so this was randomly sampled at ISQ. Yes, exactly. Yeah. Exactly. And actually, the initial sampling was even before we did the linkage with the FIPA file, so the RAMQ file that has the coordinates, which I don't know, maybe we would do differently nowadays. I'm not sure that they would agree. I'm not sure how we would do this, but that's the way that we had to proceed. So there is, a big decrement. So in the end, what this analysis suggested was that there was no selection bias, and basically this series of analyses supported the validity of our two-stage sample. And now I'm not doing. Yeah.
So if you start with 1200 and end up with 400,
yeah.
I guess you could conclude that there's no imbalance in selection bias, but still quite a selective subset, right?
There's, in the end, it's about 34 to 39% of the people that we selected initially. Now, we lost some when linking with the RAMQ, when getting the phone numbers, and also when contacting them through, But what we're seeing is that even though some characteristics are different among those who participated and those who did not, they don't seem to differ across strata, which actually would have been the main.
Right. So maybe selection bias is 30.
Yes. Even selection bias. Yes. Yes. I'm getting there. Just, yes. No, but that's perfect. That's perfect. I love it that way. Yes. So it has to be asthma in childhood because we stopped the follow-up at 20 years of age. But I'm getting there on the main. So let me just tell you about the exposure definition. Very easy. BCG vaccinated, yes or no, based on the information that we had in the registry. And then age at BCG vaccination, so unvaccinated, vaccinated before 1 year of age or at or after 1 year of age. The program was in existence. It was the last year, and we can see that there's the proportion of, for example, newborns who were vaccinated that year is actually very similar to the previous years, and then afterwards it really drops. Yes. Same calendar year as their birth year. Yeah. So there is uncertainty there. Yeah. And actually, for the first year of life. Yeah. Yeah. Exactly. Exactly. So there is. Yeah. Yeah. Yes. Yeah. So the second category has more misclassification than the first one, and thankfully, the bulk of our people are in the first category. And that's actually what we see when we go back to the actual vaccination certificates. It's often 2-3 days after birth, 10 days after birth. It's really most of them that are in the first year are really right after. We have the institutions that are recorded in the registry and on the vaccination certificates. Some of them were done at the hospitals per se, and there were some big reference centers as well for vaccination. So this is BCG vaccination. The outcome, how we defined it, we used physician billing claims and hospitalization data. So they don't start in 1974. Physician billing claims, the database begins in 1983, so we're missing a little bit of the period earlier on. And hospitalization data begins in 1987. We used ICD-9 code 493, so including all types of asthma. And the case definition that we used was 2 or more physician billing claims or medical visits, or at least 1 hospitalization with a diagnosis of asthma. Yeah, it starts at age 9. Yeah, 8 or 9, depending on when. Yes, yeah, that's when it starts. We know we have the age at which they had their first consultation or medical service. So this we were able to establish. Yeah. Yeah. Well, we end up having what we have is from age 8. So we're even because the starting age 8. So it's we're missing we're missing those that who would have outgrown their asthma. Yes. Yeah. No, you're right. You're right. Yeah. 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 We did not apply it here, and now we're actually looking, because in the telephone interviews we gathered information about this. This we had to do before we had this information, but we have self-report on asthma as well, and we're actually looking at agreement between self-report and different definitions of asthma right now. And what we're seeing is that we have better agreement when we're not using this time window. But I mean, it's we could redo. Yes. Yeah. Yes.
10 minutes to run through as much as you can.
Yes, I will.
I'm sure there's still more
Yeah.
questions, but at least we'll give you 10 minutes.
And I'll be happy to answer any questions. So this was the different references that I had there were for the different validations that had been done in the Quebec population, in the Ontario population, and actually Lisa Licks did some validation of various asthma definitions in Manitoba, comparing with self-report from the CCHS, which is quite interesting as well. In terms of covariates, what we did, because it was very difficult to come up with, I think it was impossible to come up with just, okay, this is our map of for sure potential confounders. What we did is an empirical search for confounders, where we considered any variable that had an association with either BCG or asthma. And basically, in a multivariate model, we retained them if they had a p-value less than 0.10 or if they changed the estimate by more than 10%, the estimate between BCG and asthma. And this is roughly what we considered in terms of the variables, so those that were available in the administrative databases, which we've discussed about before. And then from the interview, parental education, mode of delivery, breastfeeding, daycare attendance, presence of pets in the household. And for those, there were different sub-questions in terms of timing of exposures and different aspects that I'm not showing all in details here. And after the search, those variables that were kept in the model were really area of residence, income, breastfeeding, family history of asthma, mainly the mothers and the fathers and the siblings' history of asthma, and the family history of allergic diseases, specifically the mothers and the fathers. So this was these were the adjustment variables in our final model. Maybe that's going to answer your question. So basically, from the stage 1 sample, we can estimate an unadjusted odds ratio. And we can do a partially adjusted odds ratio with the variables that are available in the administrative data. Then we have our sampling fractions. We can here estimate a fully adjusted odds ratio with all the variables, including those from the interviews. But we need to correct this odds ratio for the sampling fractions that we use, because we didn't sample randomly among all the different cells. And in terms of the analyses in our final OR, we can use the beta parameter from the logistic regression in the stage 2 sample that includes all potential confounders. And we also need to adjust this using a correction factor for the sampling fractions. And this method for the analysis of 2-stage sampling studies is very well explained in an article by Jean-Paul Collet, which, if you're interested in the method, it's very well explained with a numerical example. You have to also take into account the sampling into when you estimate your variance. And I'm not going to go into details about this, but we can talk about it after. So just a little bit of information on BCG vaccination in the stage 1 sample. I already told you that 46.5% of the subjects were vaccinated. Age at vaccination, actually most of them were vaccinated before 1 year of age. That's 43% of the cohort. If we look at asthma, in the stage 1 sample, 7.7% met our definition of asthma, and it was a little bit higher in females than in males. And in the stage 2 sample, it was 51%, but that's really by design. So, just getting to the main results. So what we saw in the stage 1 sample, which is only adjusted for those variables that we had in the administrative databases, what we see is a slight protective effect of BCG vaccination, or a slight negative association. Not much difference according to age at vaccination, except that smaller numbers here basically is not statistically significant. Now, if we look at the final estimate from using data from the stage 1 and the stage 2 sample, what we see is an odds ratio of 0.95, suggesting no association. So once we adjusted for these additional potential confounders, we did not see the association anymore. And same with age at BCG vaccination. Just going to go through this quickly. We did analyses stratified by sex, and you can see that based on the stage 1 results, they were not that different. Now, when we when we fully adjusted them, we concluded that there was no association, but there seemed to be maybe a signal among boys of a protective effect that we didn't see among girls, but I don't think it's a strong signal, and I don't think that it's something. There's no a priori hypothesis for which we would see an association in boys and not in girls. So we just reported it as is, and basically mentioned that we did not think that the results differed by sex. So in conclusion, this is the largest study that, to our knowledge, that was ever conducted on BCG vaccination and asthma occurrence. We observed a reduced risk of asthma in the first stage, but that completely disappeared upon full adjustment with the additional confounders that we collected. So in conclusion, we found no association between BCG vaccination and asthma occurrence. And I just wanted to mention that we have explored and will continue exploring alternative methods to analyze the data that we have, namely through multiple imputation and through inverse probability weighting methods. And I just wanted to mention that we have some ongoing projects on lymphoma and on multiple sclerosis. And basically to address these diseases that are rarer, what we did is we enlarged the cohort, so multiply it by 5 by including persons born from 1970 to 1974. And so that we've had the data for less than 6 months. We have 400,000 persons in this cohort, and they're now followed up until 2014. So when they're 40, 45 years of age. So I can skip this. Yeah. It's the situation is different depending on the outcome that you're considering. So it was considered for multiple sclerosis and for lymphoma that we had the main confounders in the data set and that we could adequately address other ones by using simulations and doing some bias analyses. It was, yes, much higher, yeah. For these ones, we don't have a stage 2 planned. We're thinking about doing a study on inflammatory bowel diseases, for which we really feel that we absolutely need a stage 2. And for this, we're planning telephone interviews. Oh, there's a question in the back. Yeah. Yes. That's a good suggestion. We didn't explore. We really considered rural urban as a potential confounder, but I like the idea of considering it's stratified. We're going to look into this. Thank you. Yes. Mm-hmm. 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 It's not ideal. There are ways. Well, we don't have a postal code from the birth registry. So, oh yes. Well, this we have asked at the interview. We considered actually in the factors that we considered from the interview, we included education. We have also asked information about parents' occupation, which is nice, and we haven't really fully explored it. We also have the residential history, and so we have the postal code, or sort of the address, more or less, on about where their parents were living when they were born. So this we can, but yeah, this we can go back to and explore, definitely. Yes.
Has BCG vaccination changed over time?
You mean? Do you mean the strain that was used? Yeah. Well, there might be some drifting over time.
So Marcel looked
yeah.
at this, right?
Yeah.
But basically, the Armand-Frappier strain that he had was different from the evolved. But then for the last, I don't know how many years, it's frozen and all that. But really, now that they're freezing strains and they don't just keep growing them in the last forever, that's what they used to do. Before every strain kind of slowly evolved and different. But then sometime in the 50s, they started freezing strains for so this mutation process was largely stopped. Evolution stopped. So certainly everybody would have got a very similar strain.
Mm-hmm. And there were not different strains that were used in Quebec. Also, it was always the same. It was the same. Yeah.
That's really whatever, but that's another entire talk.
Yeah.
There's no way of assessing where we talk about in terms of the birth cohort.
Nothing before age 8. No. No, exactly. The data is not available before that. So you have.
I mean, this is really the last year of big coverage.
74. Yes,
Yeah, 75.
definitely. And we had to make some strategic decisions because I wanted to use the most recent birth cohort that was available in the BCG registry, because along with this came better quality from the birth registry data. And so when we decided to expand it, we couldn't go to the more recent cohorts because they're not vaccinated. We had to go back. We couldn't go back too much because before the 1970s, the quality from the birth registry really just wasn't sufficient for what we wanted to do.
The BCG was a very unique cohort in the world. Very unique.
Actually, even people from Scandinavia and the Nordic countries, when they saw this, presentations from these results, they said, "Oh wow, you have, amazing data." Just this coming from them is really something. Yeah. So just. Yeah. Yeah.
It wasn't so much an individual decision. There were areas where 90% of the kids got vaccinated, other areas where 10% got vaccinated. It's much more kind of random.
More.
Yeah. Allocation.
So I wouldn't. Sorry.
We need to clap.
Let me just say thank you though, because this was done by a big team, and a lot of the data, the results that I presented was actually the work of Mariam Elzain, who did a postdoc and stayed on with me afterwards as a research associate. And part of the team were Andrea Benedetti and Dick Van Hees, longtime collaborators. Thank you so much.
Great way to end our first year.